Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by Dr. Sharon Solomon, the Katharine M. Professor of Ophthalmology at the Wilmer Eye Institute at Johns Hopkins. And today we are discussing common issues that can develop in the eye as we age. So welcome, Dr. Solomon, and thank you for joining us today.
Thank you for having me. My pleasure.
With aging, our bodies go through endless changes on a cellular level. So I assume that that also applies to our eyes as well, that they're no different than the rest of our body?
That is correct. So we have several parts of the eye in particular that age and change function as we get older. I think most commonly people are familiar with the need to hold the menu farther away as we hit age 40, and that is called presbyopia. And that is secondary to the proteins in the lens, which is the focusing part of the eye that we're born with. As we get older, the protein composition of the lens, for instance, changes, and the lens is no longer able to change shape. So when we're young, in our childhood, adolescence, young adulthood, one can look in the distance and focus and immediately look up close to a book and refocus instantaneously. And as we get older, we lose that ability, for instance, for the lens to change composition. We begin to need reading glasses. So that's just one very, very common aging change that occurs universally in the eye. There are others, of course.
What can we do to protect our eyes from this kind of deterioration?
Well, presbyopia is actually just a normal aging process. So unfortunately, there's nothing that has been shown to prevent presbyopia. But there are other diseases that are age-related, such as age-related macular degeneration. The incidence of glaucoma increases with age. And I would say the best protection from visual damage secondary to these diseases is just having routine health maintenance. And of course, if a person experiences any subtle change in vision or visual field or quality of vision, to seek ophthalmic care immediately, because the sooner disease is caught, we have significant interventions that can prevent loss of vision.
What changes then are out of our control and, in essence, not preventable?
There are some diseases that are, despite being common or more common as one ages, they're still genetically linked. So for instance, age-related macular degeneration occurs typically in people who are over 50 years old, but it is not part of the aging process and universal, for instance, the way getting cataracts is. People who develop age-related macular degeneration tend to be people of European descent, light-colored eyes, fair-colored skin, and there is a genetic predisposition for this disease in Northern Europe and in North America compared to other parts of the world, although people of all ethnicities can develop this disease. So that is something that is genetically based, and unfortunately, there's no way to prevent it. Population studies have shown there's a strong correlation, for instance, to tobacco use and to high cholesterol, cardiovascular disease. So in I would say, minor aspect, modifiable risk factors for age-related macular degeneration would be cessation of tobacco use. But the genetic component really overrides all else.
What is it about tobacco that contributes in this negative way?
There are oxidizing effects of tobacco. With age-related macular degeneration, the disease process is believed to be secondary to the buildup of materials from cellular metabolism. So the same way we as individuals eat and we create waste products, the cells in the retina take in nutrients and they create waste products. And if the retinal tissue cannot keep up with clearing these waste products, they build up. And there's something about the chemicals in tobacco that may enhance that process. And the buildup of these materials are the earliest clinical signs in the retina of age-related macular degeneration. People have probably heard the term drusen, which are little yellow deposits. Drusen stems from, I believe, a German etiology that means gold nugget, and that's what they look like in the retina. And with enough buildup of drusen deposits, the drusen predisposed to cracks in the outer retina called Brooks membrane, which then allow bleeding to occur below the retina. And that can cause the dry, milder form of age-related macular degeneration to progress to the more aggressive, what we call wet or neovascular stage of age-related macular degeneration, which causes significant loss of vision.
Do we know if this applies to secondary smoke as well, or just the individual who's doing the actual smoking?
That's a good question, and I'm not aware that population studies have delved into it enough to know that it's secondhand smoke as well. I think it's reasonable to extrapolate that if somebody has a significant number of tobacco years, even via secondhand smoke, I'll bet you that there probably is some relative increase in risk for manifestation of the disease, but I'm not aware of any study that has looked at that directly.
Okay, thank you. What medical advances do we have now that help prevent our eyes from declining over time?
Well, I have to say, in the 20 plus years that I've been at Hopkins, we've undergone a revolution, particularly in retina, with how diseases like age-related macular degeneration are managed. 20 years ago, we had thermal lasers or heat lasers that were used to burn the retinal tissue to stop these aberrant blood vessels from growing below the surface of the retina, which could cause significant and abrupt loss of vision. However, by treating the retina with thermal laser, we as physicians also induced abrupt loss of vision. In clinical trials, it was still better to have treatment with thermal laser than not to have treatment, but the treatment itself caused loss of vision that the patient perceived. Nowadays, we have intravitreal antivascular endothelial growth factors that we deliver directly into the vitreous cavity in an office setting. These are monoclonal antibodies that bind receptors and prevent the vascular endothelial growth factor that is elevated in the diseased eye from spurring the growth of these aberrant blood vessels. So it is not uncommon now to have patients who come in monthly to get treatment, and we have patients who have the quote unquote more severe form of age-related macular degeneration, yet the patient maintains 20/20 vision, 20/25 vision. Many patients are getting bilateral treatment every 1 or 2 months, and they actually maintain driving vision and reading vision. So it's really been a revolutionary addition to the armamentarium for how we manage, in particular, age-related macular degeneration, which is the leading cause of vision loss in people above age 50 in North America and Europe.
That's fantastic. Now, you said monoclonal antibodies, and our listeners probably have heard that term associated with the COVID pandemic and using that specifically for COVID as a treatment. So I just want to emphasize to our listeners that we're not talking about COVID right now. We're talking about the eye, and it's a different kind of monoclonal antibody. There's commercials on television chronically advertising different types of eye drops. Some are over the counter, some require a prescription. Is there value in eye drops as well as in vitamins, where you'll read on the package that this will improve your sight or make your vision clear, or various things that they will advertise on the packaging, so that people are exposed to it on the TV, on the radio, and then when they go to their local pharmacy, there'll be signage in there that says this is going to make your eyes look brighter or healthier. Can you comment about that?
I think that a lot of those advertisements are targeted to people who have dry eye syndrome, for instance. And dry eye syndrome can really run the gamut of just having transient dryness because you're doing a lot of computer work, or because you have the air conditioning on in the room and your eyes are drying out. But then some people can have really severe vision debilitating dry eye because it's secondary to systemic disease, like rheumatoid arthritis or some sort of vasculitis. These conditions tend to be more common in women. They tend to be more common in adults, certainly ages 50 and older. In a case where one truly has the clinical diagnosis of dry eye, then it does become essential to use lubricating eye drops numerous times a day. Sometimes we tell patients to put them in every 2 to 3 hours throughout the day and to use lubricating ointment in the eye at night. I don't think that these medications are preventative, but if you develop dry eye symptoms or dry eye disease, it's certainly manageable and it's easy to manage unless you have, like I said, secondary dry eye to a systemic condition, in which case the prescription eye drops that you see advertisements for, such as Restasis, Xiidra is a new one. Those are immunosuppressive topical drugs that will often increase tear production and are a more aggressive way to treat dry eye. So that covers the topical advertisements that we see for eye conditions. You referred to vitamins as well. And I caution my patients that a lot of the vitamin commercials, of course, are targeted to the general population. And I don't think that that's appropriate. Clinical studies, many of which were sponsored by the National Eye Institute, and I'll reference the age-related eye disease study or ARID study, showed clinical benefit in taking antioxidants systemically. So these are vitamins that contain high doses of vitamin C, vitamin E, beta carotene, and zinc. And in clinical trials, those have been shown to slow down the progression of milder forms of age-related macular degeneration. So in a patient who carries the formal diagnosis of age-related macular degeneration, taking the vitamins has been shown compared to not taking the vitamins to slow down progression of disease. And even in patients who have later stages of the disease, if vision is 2100 or better, the vitamins have been shown to increase the chances of maintaining that level of vision. So I think it's appropriate to take vitamins, but only for that one diagnosis, which is age-related macular degeneration.
So we don't want people to go to the store and buy these thinking that they can prevent this from happening. Oftentimes, we know that the consumers do think, well, if I take it beforehand, that'll be even better. So it does require a discussion with their doctor for sure, and not to self-medicate, because no pill that goes in your mouth is free of risk.
Exactly. And that's a very important point, because in the clinical trials, they did show that there was an increased risk of prostate problems, quote unquote, not cancer, but problems in men, an increased risk of kidney stones. So there was morbidity associated with the vitamins at very low frequency, but there's no data to show that it prevents the onset of age-related macular degeneration. So I counsel my patients who do not have the disease not to take the vitamins, because then they're only exposing themselves to risk with no benefit profile.
You touched earlier on one of the age-related conditions that affect the eyes, which is cataracts. Can you talk a bit more about that? What are the signs and symptoms that someone would experience to let them know maybe they are developing or have developed a cataract, and how is it treated today?
Cataract, like presbyopia, is something that's completely universal. If we live long enough, all of us, 100% of us, will develop cataracts. And what that is the same lens that begins to lose the ability to change shape and causes presbyopia around age 40. As we get past age 40, that lens also begins to change color and to become more opaque. So an early symptom of cataract progression is simply that patients feel that they have greater blur with their vision. They begin to notice that glare from oncoming headlights at night bother them. They need greater light with reading. All of those symptoms are common, and we hear that universally in our patients. There's no preventative treatment for cataracts. When the ARID study, the age-related eye disease study, was looked at, they also looked at whether administering vitamins would help decrease cataract progression, and they did not find that that was the case. So we're all bound to develop cataracts. Whether or not the cataracts get to the point where they bother us enough that we want to have surgery is a different issue. So the definitive treatment, when one has clinically significant cataracts that impact your quality of life, is to undergo cataract surgery. And over the last several decades, cataract surgery has become extremely streamlined. In the hands of an experienced surgeon, it is not unusual at all to see a 10 or 15-minute cataract surgery. Cataracts are still the leading cause of blindness worldwide. And when you see places like the Aravind Eye Center in India, where in 20 minutes they take out a patient's cataracts bilaterally. It's a life-altering event.
And you're right, looking at this being a much shorter period of time to do this type of surgery, but the recovery is quite different today than it was, say, 50 years ago, where a patient would be an inpatient for a week, sometimes even as long as 10 days, and kept flat. I mean, we treated them like they were a hand grenade with the pin already pulled. It was a very, very different experience. So that's a wonderful example of the tremendous progress that's been made in that arena. Let's talk about glaucoma, another condition that's associated with aging. So can you tell us what glaucoma is and what age does it usually develop if it's going to, and how often should your eyes be examined to look for the presence of glaucoma?
Those are excellent questions. Glaucoma, unlike, I would say, age-related macular degeneration, is a very heterogeneous group of diseases. So for instance, there's something called juvenile glaucoma, where younger people in their teens or even as children can develop glaucoma. That might tend to be hereditary. There is primary open-angle glaucoma, which we tend to see in adults, and that tends to have an ethnic as well as a genetic predisposition. So that tends to be more common in people of African descent. But in general, the more common type of glaucoma that we see is correlated with aging. But I would tend to say that people do have a family history of glaucoma. And what glaucoma is an imbalance in the production of eye fluid and the outlet of eye fluid. So some people develop glaucoma because they have poor outflow. The natural fluid that the eye produces and turns over can't escape from the eye. So you have this constant buildup of fluid. Other people, for instance, people of Russian ancestry, more commonly will develop something called pigmentary glaucoma, where the pigment from the iris constantly is released and it blocks the outflow tract of the eye, and they're more predisposed to a certain kind of glaucoma. So it's a very heterogeneous group of diseases. There's nothing preventative for glaucoma. So the best guard against that is if there is a family history, especially in somebody, say, of African descent, and they have relatives who have lost vision. And I should mention that with glaucoma, the loss of vision can be insidious. So unlike with age-related macular degeneration, where patients tend to become aware of the deficit immediately because it involves reading vision, central vision, glaucoma is insidious because it involves loss of peripheral vision. And some patients may not notice it affecting their everyday activities until it involves their central vision, in which case it's already become end-stage glaucoma. The recommendation would be to anyone who is aware of a significant family history to actually start having annual exams, perhaps annual visual field testing to screen for glaucoma. The eye pressures are checked because commonly eye pressure will be elevated with glaucoma, not always, but oftentimes. So the best prevention there is, again, routine health maintenance with annual exams. And then, of course, if someone is a glaucoma suspect or has borderline findings, a glaucoma specialist will dictate how frequently the person should come in for nerve fiber layer assessment by optical coherence tomography, a newer modality that we have to examine eyes, and or visual field testing.
Can we talk a little bit now about diabetic retinopathy? There are millions, as you know, millions and millions of people that have diabetes in the United States. They may be seeing their PCP, they may even be seeing an endocrinologist, but they aren't necessarily also getting their eyes examined by an ophthalmologist unless they're having some acute vision problem, because they figure, well, my diabetes is being managed, so I shouldn't have to worry about something going wrong with my eyes associated with my diabetes condition.
I think that's a very important topic to touch upon. If age-related macular degeneration is the leading cause of blindness in people 50 and older, diabetes is the leading cause of blindness in this country in people who are working age adults. And I've been a surgeon for more than 20 years, and I can tell you the toughest cases that I've done that involve detached retina come from patients who have end-stage diabetic retinopathy. it's imperative that when someone is diagnosed with diabetes, that depending on the type of diabetes, one might argue certainly within 5 years of diagnosis, they should start to have routine annual dilated fundus examinations of the retina. But oftentimes people are diagnosed and they've had diabetes for years already. So depending on the type of diabetes, patients should really begin to see an ophthalmologist for dilated eye examinations at the time of their diabetic diagnosis. Because it's a systemic disease, the mainstay of prevention is to maintain tight control of the hemoglobin A1C and tight blood glucose control. Until there's a cure for diabetes, you can't control how long you've had the disease. But certainly the better controlled the systemic disease is, the less likely it is to cause secondary microvascular changes in the retina, the kidneys, the heart, et cetera, all the organ systems that are involved in diabetic retinopathy. That being said, there are different stages of diabetic retinopathy. There is a non-proliferative stage that is very common and we tend to see within 10 years of diagnosis, where we see small intraretinal hemorrhages and exudates that leak from capillaries in the eye. Oftentimes, that does not require treatment unless it involves the central macula, in which case, if it causes swelling of the central macula, which affects reading, the same intravitreal anti-VEGF agents that were shown to be beneficial in the management of age-related macular degeneration have also been shown in clinical trials to benefit patients with respect to maintaining reading vision. So we use that in-office intravitreal injection procedure very commonly for patients who have diabetic retinopathy and diabetic macular edema. If patients progress to the latter stages of diabetic retinopathy, known as proliferative diabetic retinopathy, where they can have diabetic blood vessels grow on the surface of the retina, they have secondary bleeding into the cavity of the eye called vitreous hemorrhage, and beyond that, they can have detachment of the retina. Oftentimes, we're talking about having to take the patient to surgery to clean out the vitreous cavity, perform peripheral laser photocoagulation, still use anti-VEGF agents, but use more aggressive means of reattaching the retina. Diabetic retinopathy is a formidable disease that can cause significant loss of central and peripheral vision because of circulation compromise and ischemia, but the intensity, the degree of devastation really can be lessened by the patient's understanding how important the systemic control of the disease is.
I know that's going to be helpful to our listeners because they may be a diabetic themselves or married to someone who has diabetes, or for that matter, have children or grandchildren in this situation because it is such a common disorder. How about thyroid disease? There's some types of thyroid disorders that impact the eye as well.
Yes, that is true. So with thyroid disease, what one will often see is a clinical appearance where the eyes appear to bulge from the orbit. That can predispose to dry eye. So thyroid eye disease is a common reason to have dry eye because you may have exposure, for instance, when the person's sleeping at night, because the eye protrudes from the orbit. They may not get good lid closure. And with being disinhibited as you sleep, the eyes might open a little bit, the lids might open a bit, and the cornea can become exposed. So that could be a common reason to have dry eye. In extreme cases, one could have thyroid orbitopathy that actually can stress the optic nerve. In other words, the eye can protrude to such an extent that the connection of the optic nerve from the back of the eye to the optic nerve chiasm in the brain, that can be stretched. And you can actually begin to get visual changes because you're affecting how well the optic nerve now functions because it's being pulled by this protruding eye. So in those cases, patients may even have to undergo surgery to relieve the thyroid orbitopathy.
Tell me your thoughts regarding LASIK surgery for correcting visual acuity, because that is so common today. We don't even talk about it as being something new. Over 30 years ago, this started, and I think it's pretty commonplace today. Are there certain individuals that would be candidates and others that probably would not be? And are there special consideration that a consumer should be aware of that now they may need to pay more attention to after they've had this type of procedure?
Like any surgical procedure, the recommendation, of course, would be to be assessed by someone who has a tremendous amount of experience performing the procedure, simply because, especially with LASIK surgery, the debate, especially when it came out decades ago, is that you're taking a perfectly healthy eye. There really is no underlying disease. It's not like performing surgery for glaucoma, because if you don't, vision will be lost, or surgery for a detached retina, because if you don't, vision will be lost. Typically, people who have LASIK surgery tend to be people who are very nearsighted. We call them high myopes. And they can see with their glasses, they can see with their contact lenses, but they'd rather not be burdened by having to wear glasses all the time or having to put contact lenses in every day. So you're taking a healthy eye and changing the contour of the retina by performing various types of laser procedures in the stromal bed of the cornea. And for the most part, patients do well. And I think as the procedure has been refined over the last couple of decades, I think the success rate honestly is quite high. The joke among ophthalmologists is you may often see the cornea doctor who does LASIK wearing glasses himself. And the response would be, I can't risk not having a good outcome myself because this is my career. I need to wear my glasses because I can't run the tiny risk of developing an infection or having my LASIK flap becoming displaced and losing vision, even if it's a line of vision, because I need to have that 20/15 extra perfect vision in order to perform LASIK surgery. But in all seriousness, I would say that it has come to be a very successful surgery. It's still done very commonly. There was a concern at one time whether it increased the risk of retinal tears or detachments. And I think that with time, that concern has lessened, because I think that people realize that the pool of people who are having LASIK surgery already have an inherently higher risk than the general population of having a retinal tear or detachment, because they tend to be very myopic. Those are the people who tend to seek out LASIK surgery. To answer your question as to who would not be a good candidate, again, this is not my clinical expertise, but my impression is that people who are at the age where they're also developing cataracts might not be the best candidates for LASIK, because then it becomes tricky to decide what part of the visual deficit is because they would benefit from having refractive surgery and what part of it is because of the cataract. So I think that if you have an incipient cataract and you're getting to the age where it's time for cataract surgery, that likely is not the best time to consider refractive surgery.
That makes sense. I'm sure that all of us at some point in time have seen a toddler wearing glasses. And I've had many of my friends ask me over the years, how does an eye doctor figure out that a child needs glasses? And how do they figure out what kind of lens do they in fact also need? Can you enlighten us on how that's done? Because obviously this is a youngster who doesn't know their alphabet yet. So they're not looking up there at the big E and the next row and the next row. So how does that happen? How does that come about that they figure that out?
There's an art that some optometrists perform, and certainly pediatric ophthalmologists perform, where they do what's called a cycloplegic refraction. They can dilate a child's eyes with dilating drops, and then they use a special light. It's been so long, I believe the procedure is called retinoscopy, but they use a light to see what the reflex is from the retina and the lens. And that helps them to calculate what the child's refraction should be. So that can be done in nonverbal adults. That can be done in infants and children. And if there's any, especially for children, if there's any suspicion that a child may have a lazy eye, because one eye could be very nearsighted and the other is not, And the pre-verbal child may not be able to tell you, gee, when I'm looking at the pictures in my book, only my left eye is seeing the pictures. My right eye, the pictures are out of focus. When they do this assessment, they can pick up refractive differences between the two eyes and correct for it early. And in children, especially less than 2 years of age, that's critical because the brain is still developing vision. So it's not so much the eye that becomes the rate limiting factor, but if there is a discrepancy in refraction between the two eyes, which is a type of amblyopia or lazy eye, if that's not corrected by a certain time, input from that eye is not getting to the visual cortex that corresponds to that eye. And later, if the eye is corrected, unfortunately, the brain has not developed vision, and the child will have a permanently amblyopic or lazy eye. But cycloplegic refraction is what you're referring to.
Okay, very clever, very clever. Is it true that when a baby is born, the size of their eye is the size that it remains into adulthood, or do our eyes grow as the rest of our body grows?
That's an excellent question. Our eye definitely grows as the rest of the body grows. So for instance, there are babies who are born prematurely, and if they had oxygen exposure or just because of being born prematurely, they could develop retinopathy of prematurity. And they are unfortunately prone to having detached retinas. And some of those babies will have the retinal detachment repaired by placing a scleral buckle, a silicone band around the outside of the eye, below the eye muscle, to keep the retina attached. We do the same procedure in adults as a primary way of repairing detached retinas. In babies, the buckle will be a different size, and that buckle may not always be the same buckle that the child will keep into adulthood. Sometimes it is, but oftentimes it may not be. In people who are myopic, especially, you can sometimes see that eye grow well into adulthood. I do not recall, although I think that it is generally known what age eyes tend to stop growing. And I think it's actually, I'm guessing it's definitely before adolescence. I don't think it's typical to see an eye grow beyond adolescence, but in rare individuals, you may have the eye grow into adolescence, and those people end up being very high myopes. They have an axial length or a length of the eye that is much higher than the average eye.
Wow. I had a very dear friend and was a very close friend of my parents as well, Dr. Richard Hoover, who was an ophthalmologist at Hopkins many, many years ago. He passed away in the early 1980s. I met him when I was in elementary school, and I remember him saying to me, "Do you know the most important organ in your body, Lillie?" And I remember saying, "Yes, it's the heart." And he said, "No, it's the eye." I will never forget that discussion with him. And when I had our daughter, he gave me a framed poster, and it was a picture of a little girl's face, a little toddler's face. She looked so excited, all just lit up. And the caption said, "See as a child sees, the joy, the wonder, the hope." So I'm so pleased that you're at Hopkins and that you're in this very significant role for us at Johns Hopkins in helping people maintain their vision so that they can see the joy, the wonder, the hope, I hope also as an adult. Dr. Solomon, if there was one piece of advice that you would leave our listeners with today, what would that be?
Well, I think you summed it up nicely when you referred to patient preferences. Studies have looked at, do patients value losing a limb, losing vision, having a stroke? And studies have shown that some people would rather die, suffer a stroke, or lose a limb than lose vision. So vision is highly, highly valued. It's how we see the world. And the old adage, it's the mirror to the soul. So the advice would be for patients to take good care of their eyes. We're all busy. We tend to say, "Oh, I'm not seeing well," and you ignore it because you have to go to the next meeting, you have to do the next Zoom call, whatever. But the same way we're trained, if you have chest pain, it could be a heart attack, nothing to be ignored. If you perceive loss of vision, even if it's transient, we need to have evaluation. It's surprising, but I've had many well-informed, educated patients come in and they tell me, yep, I noticed the loss of vision 3 weeks ago and there's a detached retina. And you're thinking, my goodness, what were you thinking?
Wow.
And time is of the essence. There are some conditions that are forgiving and you can have loss of vision for days, weeks, or months, and there's treatment to regain vision. But there are other conditions like glaucoma, detached retina, where unfortunately, if the issue is not managed within hours to days, vision can be lost permanently. So I would just say to have good health maintenance for vision.
Excellent. Excellent. Well, Dr. Solomon, thank you ever so much for this very valuable information. I know that our listeners are going to take it to heart and not just make sure that they're doing a better job with their own ocular health, but probably also, as is the tendency of most women, taking care of their family members as well, their spouse, their adult children, their children that are still in school, so that everyone can take advantage of taking in the world as intended. We really do appreciate you being part of our monthly Insights That Matter podcast series, so thank you.
My pleasure. I really enjoyed spending time with you. Thank you so much for the great questions.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.